Welcome back to The Explainer. Today, we're going on a deeply microscopic investigation into what is honestly one of the most notorious pathogens in human history. We're going to dive into exactly how a remarkably sneaky virus manages to completely hijack the human body's own defense mechanisms, essentially turning our inner protectors into literal factories for its own replication. It's a fascinating, if somewhat sobering, biological heist. And, really understanding how it pulls off this trick is absolutely crucial to understanding how we can fight it.
To make sense of all this, we're going to take a sort of zoom in, zoom out approach today. First, we'll define HIV and AIDS. Then we'll zoom way in to see how it hijacks the immune system at the cellular level. After that, we'll zoom back out to track the 3 stages of infection, look at the modes of transmission, and finally wrap up with diagnosis and treatment.
All right, let's jump into Section 1, defining HIV and AIDS. To truly grasp what's happening, we've got to clear up a really common terminology mix-up right out of the gate.
So people often use these two terms interchangeably, but there's a really critical distinction here. HIV, the human immunodeficiency virus, that is the actual physical virus itself. It's the physical pathogen that enters the body and zeroes in on your immune cells. AIDS, on the other hand, which stands for acquired immunodeficiency syndrome, well, that's the eventual condition that happens when the immune system starts to really fail. It's the resulting state of immunodeficiency that opens the door for other infections and tumors that a healthy body would normally just, swat away without a second thought. Basically, HIV is the invader and AIDS is the biological fallout. Oh, and just a quick technical note. When we talk about HIV, we're almost always referring to HIV-1. It's the most common type worldwide. HIV-2 exists, but it's incredibly rare and mostly localized to parts of Western Africa and Southern Asia. So for the rest of our explainer today, when we say HIV, we just mean HIV-1. Moving on to Section 2, hijacking the immune system. Now this is where things get wild. We're zooming all the way down to the cellular level to watch this heist unfold.
You've probably heard HIV called a retrovirus before, right? Well, that retro label has absolutely nothing to do with vintage style. It actually refers to its crazy mechanical ability to essentially reverse engineer its own genetic code. See, HIV is a single-stranded RNA virus, but it brings along a very special enzyme called reverse transcriptase. And this enzyme's whole job is to transcribe that RNA backward into a complementary piece of double-stranded DNA called proviral DNA. It's prepping its genetic code so it can literally copy-paste itself into the host cell's DNA. Think of it like a home invasion, step by step. HIV specifically targets CD4 positive cells. These are your heavy hitter immune cells, like macrophages and T helper cells. Step 1. The virus uses a protein on its surface, GP120, to latch onto the CD4 molecule and then onto a secondary co-receptor like CCR5. Step 2. Once attached, it injects its single-stranded RNA right into the cell. Step 3. That reverse transcriptase enzyme we just talked about gets to work, building the proviral DNA. And finally, Step 4, it slips into the cell's nucleus and completely integrates itself into the cell's own DNA. Boom, it's inside the fortress. But here is the ultimate Trojan horse twist of this whole thing. Once that viral DNA is inside the host's DNA, it just sits there, waiting. Later, when that immune cell gets activated to go fight off some totally unrelated random infection, it starts creating proteins for an immune response. But because the HIV DNA is now part of the blueprint, the immune cell accidentally transcribes and translates completely new HIV viruses. They literally just bud right off the cell membrane to go infect other cells. The very act of your immune system trying to defend you is exactly what the virus uses to multiply. It's diabolical. There is a wild twist of the genetic lottery here, though. Remember that CCR5 co-receptor the virus uses to unlock the cell? Well, some people happen to have homozygous genetic mutations in those very co-receptors. Because their cellular locks are basically shaped differently, the virus's GP120 key just doesn't fit. Meaning these lucky individuals have natural resistance or even outright immunity to HIV. Even people with just one copy of the mutation have a significantly harder time spreading the virus in their bodies, which drastically slows down the disease progression. Nature is amazing, right? Let's zoom back out for Section 3, the 3 stages of infection across the entire body. Generally speaking, this infection moves through 3 distinct phases. First is the acute infection. The virus hits the lymph nodes, replicates like crazy, and causes a huge viral spike, usually bringing on flu-like symptoms. Eventually, your immune system launches a counterattack, pushes the virus back, and we enter Stage 2, the chronic or clinically latent phase. This is a long, quiet standoff that can last anywhere from 2 to 10 years. And finally, stage 3 is AIDS, when the immune system's defenses basically collapse. I want to focus on that middle chronic phase for a second. A patient might look and feel completely fine, no symptoms at all, but behind the scenes, the virus is relentlessly chipping away at their defenses. Look at this number, 1 to 2 billion. That is how many vital T cells are destroyed every single day during this silent phase. The viral load in the blood is slowly creeping up, and the patient's T cell count is inevitably ticking down.
To make matters worse, HIV is actually kind of a sloppy replicator. It makes constant errors, which leads to mutated strains. This is a concept called viral tropism. Early on, the R5 strain is using that CCR5 co-receptor we discussed. But during that long chronic phase, the virus can mutate into what's known as the X4 strain. This new version switches targets to use the CXCR4 co-receptor, which is found almost exclusively on T cells in lymphoid tissue. So it literally hides out in the lymph nodes, systematically wiping out those crucial CD4 T cells.
And eventually, all of that daily destruction hits a very critical threshold. A normal healthy T cell count is usually somewhere above 500 cells per cubic millimeter, which is a space about the size of a pinhead. But when that T cell count drops below exactly 200 cells per cubic millimeter, the immune system is officially compromised. That specific line in the sand is when a patient officially progresses from having an HIV infection to having AIDS.
Once below that 200 mark, things get very serious. Patients experience persistent fevers, profound weight loss, and fatigue. But the real danger comes from what are termed AIDS-defining conditions. We're talking recurrent bacterial pneumonia, severe fungal infections in the esophagus, or specific cancers like Kaposi sarcoma, which causes distinctive skin lesions, and primary lymphoma of the brain. The sobering reality here is that people with AIDS don't typically die from the virus itself. They succumb to opportunistic infections that a normal, healthy immune system would have swatted away effortlessly.
All right, Section 4, Modes of Transmission. Let's look outward at the population level to see how this virus actually moves from person to person.
Looking at the global data, sexual intercourse is far and away the primary mode of transmission, driving over 75% of all cases. Now, the demographics shift depending on where you look. In the US, male-to-male transmission is currently the most common route, while globally, especially in resource-limited areas, male-to-female transmission is the dominant mode. And yes, female-to-male transmission absolutely occurs too, since the virus is present in both vaginal and cervical fluids. The remainder of the cases come from a few other modes. Intravenous drug use, sharing needles, is a significant factor. There's also mother-to-child transmission, which can occur across the placenta before birth, during delivery, or even later through breast milk. Then you have much rarer instances, like an accidental needle stick in a hospital setting or receiving infected blood transfusions, though modern screening has made that last one incredibly rare.
Which brings us to our final part, Section 5, Diagnosis and Treatment. Knowing everything we now know about this microscopic ninja, how do we fight back?
First step is finding it, and we essentially have 3 diagnostic tactics. Number 1, antibody tests. These look for the unique antibodies your own immune system produces when it realizes HIV is there. Number 2, antigen tests. These bypass the immune response and look for the physical pieces of the virus itself. And number 3, RNA or DNA tests. These go straight for the genetic material, hunting down the viral RNA or those sneaky proviral DNA copies hiding inside your cells. In clinical practice, the standard go-to is usually a combination antibody/antigen test. It's fantastic for general screening because it covers both bases, looking for the virus itself and your body's reaction to it, making it great for catching early infections. Of course, if that initial screening flags a positive, protocol dictates running a secondary confirmatory test, just to be absolutely certain before proceeding.
So, that brings us to the elephant in the room, the question everyone asks. If you test positive, is there actually a cure for HIV and AIDS? Right now, the short answer is no. There's no cure. But the long answer is incredibly hopeful. We use something called antiretroviral therapy, or ART. Now, ART isn't a single magic pill. It's a very specific combination of medicines designed to literally throw a wrench into the microscopic cellular heist we explored earlier. it actively jams up the virus's replication cycle. And by stopping the virus from endlessly multiplying, ART gives the immune system a chance to bounce back, rebuild its T cells, and fight off those dangerous opportunistic infections. Thanks to ART, a diagnosis is no longer what it once was. People can live long, very healthy lives and massively drop the risk of transmitting the virus. And honestly, it leaves us with an exciting question. With our rapidly advancing understanding of genetics, like those CCR5 mutations we talked about, how close are we to finally turning this lifelong management into a permanent, definitive cure? Something to think about. Keep learning, stay curious, and thanks so much for joining me for this explainer.